evening and welcome to SSBC. This is your program Voices Unheard, where we focus on human rights and uplifting marginal voices. I am your host, Emmanuel Amin. SSBC, in collaboration with Journalists for Human Rights JHR, is currently implementing a media development project amplifying voices of women and girls. This project aims to lift women's voices that are systematically underrepresented in the media, in civic life, and in governance, while tackling structural barriers, whether legal, institutional, societal, or cultural, that limit women's participation in public life and the decisions that shape their communities. Today, in our discussion on women's access to healthcare and specifically sexual and reproductive health rights, a breakdown between women, girls, and gender-diverse people. Women's access to healthcare in South Sudan is severely limited by a crumbling health system, conflict, and immense geographical barriers, resulting in high maternal mortality rates, estimated to be 789 to 101,500 deaths per 1,100 live births, only up to 19% of births attended by skilled personnel. To discuss this with me today, I am joined by Emma Koje, who's an activist, and David Sanya, a medical practitioner. You're both welcome to the studio today.
Thank you so much.
Diving into the issues and the matters at hand, we'll start by Emma here and asking that what are some of the barriers that women face when trying to gain access to healthcare, especially when it comes to maternal health?
Thank you so much. Thank you for this opportunity. When it comes to accessing healthcare services, especially on sexual and reproductive health, you find that there are a lot of barriers that women face. Just like we know the context of our country, South Sudan, which is a young nation, and a lot of things we are still coming up. And then you find in some areas that location is a barrier. Accessing the hospitals or accessing the healthcare services centers is also a problem. You'll find the distance is very long because, for example, there is no hospital in Juba town. I am in Juba town. I'm talking generally in other states. You'll find you're in Juba town, there is no another hospital until you go maybe a distance up to Gurei or up to Gumbo Sherkad, right? So it becomes very difficult because for you to access to go up to there is another problem, and it becomes extremely hard. And then you'll find also there are some government hospitals, but still there is a cost that is attached to it. So you find other people cannot be able to access because they don't have that money, or for you to even reach there to the public hospital, it needs transportation as well. And then if you don't have the money, it becomes also very hard for you to access. Sometimes you will find there is no, they can check you and all, but then medication is not in the hospital, which means you have to go and look for medication elsewhere, and you need to go and pay for it. And then it becomes very hard. Sometimes also insecurity. We know all the context of our country, and then you find maybe for example, I go into labor at night. Now for me to access to travel at that time, it becomes very hard because of what? Insecurities. So these are some of the barriers that really hinders and affects the healthcare provision, and which we really need to look into it. All of us also have we have a role to play when it comes to addressing these challenges and barriers.
All right, thank you very much for that response. Now,
one thing I forgot, sometimes you will find there are no enough skilled personnel. You will find maybe, I hear sometimes some people will be talking about they go to the public health centers, but then the personnel there, and they are not even friendly, and then there are so many things. So if we really train we have skilled personnel, then everybody can be able to have a very good conducive environment to get their services.
Okay, I think we'll get much later to the issue of personnel and stuff. Let us move on. When we're talking about socio-economic and social cultural factors, what are some of the misconceptions that you hear regarding issues to do with maternal health and also things like contraceptions and that hinder women actually to be able to access proper health care?
This is something that we are really struggling a lot, especially in our context. But I'm glad that at least a few people are already getting to understand, because like we did a lot of awareness, especially even me personally in my organization at Bernard Power, we do awareness creation. When it comes to contraceptions or contraceptives, there are a lot of misconceptions. You will find people say if you they say that contraceptives causes infertility, which is not 100% right. It's only maybe if you use it wrongly, but contraceptives doesn't cause infertility. Or they will say that contraceptives is only for women who don't want to give birth or to have children, right? Which is not true. Where contraceptive is about planning and it's about giving space to give birth to another child. We all know the context of our country economy is also not good at all. So if you're somebody who wants to space your children, you want to say, okay, I don't want to have to give birth every single year, right? I can use contraceptive to at least stay maybe for 3 years, 4 years, then I plan to give birth to another.
As a measure of family planning?
Yes, it's as a measure of family planning. It is us to decide and say, I want to plan my children, right? But then people think that if you're using contraceptives, you don't want to give birth and all. And then another thing is sometimes it becomes very hard for people to go to hospitals. People tend to, our mothers gave birth to us not in the hospital. They gave birth to us at home, right? So it becomes now very hard for people tend to say strong women don't give birth in the hospital. If you give birth in the hospital, you're not a strong woman, right? Which is very, very wrong, because there are some certain things that you cannot be able to handle at home, right? A complication might happen. So what are you going to do? It's either the mother die or the child dies. So it's better to go, even sometimes go to the hospital, check yourself, check how your baby is doing. You don't know, maybe the baby is already dead even in your womb, right? So it's very important. And then it discourages facility-based deliveries. And then coming to our context, our cultural perspective, you find that men and all the chiefs, husbands, they are the ones who have they are the decision makers, right? So it becomes very hard now for a woman to decide about her own body. Sometimes I had there is an instance where a woman wants to go to the hospital, but the husband says, no, my wife cannot give birth in the hospital. My wife has to give birth at home, right? So it becomes very difficult, because the other people cannot be able to do anything again, because the husband is the final say, Gali. The elders have already said their words. Then you cannot be able to do anything. So it becomes very hard. But this requires for us to clear all this. It requires us to have engage even the males, the elders, to understand some of these things, and also create more awareness, as well as make the community know that there are some other things that really needs all of us to work together.
All right, thank you very much. Let us move on to David Sanya. Of course, as a medical practitioner, just as we have mentioned the issue of giving birth, and of course, tell us, what are some of the primary reasons you think that most pregnant women, especially here in the country, that prefer home births over facility births, which has been put actually by the UNFPA to be about 81%. What do you think could be some of the primary reasons?
Okay, thank you so much. I think there is a lot to that. When we look at the reason why women refrain from visiting antenatal care, now of course we have the standard visits. They're supposed to be 4 visits per pregnancy. So, but you see, there are factors that comes in. just like Emma said earlier on, we have many factors like the infrastructures. You find the distance, of course, the health facilities.
Yeah.
I think those are very key things that women usually consider. And the other factor is also the cost barriers. You see, when we talk about accessing health facilities, of course, we know that these health facilities, the public health facilities, they're supposed to offer free services to the people of South Sudan. Not only people of South Sudan, but everybody in South Sudan. But there are some scenarios where the woman want to travel maybe from the village to within the, let me take a small setting in the village. Of course, when we talk about Juba, there are a lot of accessibility. But of course, there are some other factors, of course. But let's talk about the cost effectiveness of this factor. You find there is in the village, you will have to travel like maybe 15 kilometers or even 10 to access the health facility. Yeah. Now you will find this woman, for her to travel there, she may need some transportation. So you'll find there is also a cost of that transport. So some of these women says, now what if I just wait until I give birth? Yeah. Or else sometimes if they don't have the money, they will only visit once. And then the other time, if they don't have money, they'll say, I'll visit the next month. Of course, they have already skipped one visit. So these are factors that comes in. When we also look at sometimes, of course, you said earlier on, the issues of unprofessionalism. Of course, some medical personnel, they lack medical code of conduct. In common scenarios, if you go to one of these health facilities and you ask these mothers, they will say, of course, these other health worker is very rude. Yeah. Of course, they will say it. They will say, we prefer the other one. But if that person is not there, they will say, of course, now today I have to go back. You see? Because there is some attitude that are attached to their profession that is already affecting the health service provision. So you find this mother, sometimes they refuse to go for the visit, not because they cannot access, but because there is someone there who is acting out of professionalism. So of course you find they are trained, but still, of course, attitude cannot change. It has to be changed by someone. But of course, you find these health facilities, they are not supervised regularly. Of course, the health, the local government, of course, which is the county health department, of course, maybe the state ministry or the national ministry, they don't regularly supervise. They don't do supervision. Of course, when you supervise, you will get to understand that these are kind of practices that are happening in the health facility and they're affecting already service delivery. But of course, these things are not done. And at that point, it gives these health facility service providers, these loggerhead, to be like, of course, we are final, but not knowing that they are working under a specific mandate. So that is some of the challenge that is also affecting. When we talk about the insecurity, of course, you talked about it, I don't need to mention. Most of these health facilities, some of them are even destroyed during the crisis. So you find now, your next maybe your next antenatal visit is not tomorrow, but of course the health facility has been destroyed, or maybe now it is closed because everyone has run for his life. So the accessibility has been in many ways a challenge. The cost barriers, of course, when we talked about the cultural barriers, there are very many, and these are the most issues that are affecting the antenatal care. You find the mother says, of course, now there is one culture in South Sudan that says a woman that gives birth at home is a strong woman. And imagine you going to give birth in the health facility, you look weak. And of course, it's a challenge. Now every woman wants to face like, let me give birth at home, because they're already traditional birth attendants. Of course, as a ministry, the ministry is also doing its best to train these traditional birth attendants to ensure that they also be able to give services at a need, at emergencies.
This is the traditional midwives.
So they are there. They are also capacitated by the ministry. But you find their community is already taking it as an initiative that these people can even do what can be done in the health facility, not knowing that there are other emergencies that may need other support. So this birth attendant is trained to deliver you, but in case of emergency, they cannot be able to help.
Like a hospital.
So you can deliver at home because there is already someone who is trained to deliver you. But the problem is, how sustainable is that delivery? Because some of these birth attendants, they don't know some of these emergency response. Of course, maybe there is there is delayed labor. Of course, maybe obstructed labor. So this child may need resuscitation. So how will they resuscitate? So you find some young girls, they want to deliver in the house, but you find they're very young. What if something like, what if there is a hemorrhage? So there is postpartum hemorrhage. So how will they respond? It will be very hard. You find they now want to transfer the child, the mother to the facility for further help, but now it is very hard.
It's too late.
It is already too late. You find they reach in the hospital when the mother has already lost a lot of blood because of the postpartum hemorrhage, and the mother dies. So these are some of the things that they are encouraging home deliveries.
Thank you very much, David Sanya, for that response. Dear viewer of SSBC, just to remind you, of course, in the studio with us is Emma Kwaje, an activist, and David Sanya, a medical practitioner. Of course, this is your program, Voices Unheard. Let us go for a short break, and after we come back, of course, we will continue with our discussion of women's access to healthcare, and specifically sexual and reproductive health rights. Let's go for a break, and we shall be back.
In a world full of noise, some voices are never heard.
As they help me to handle my finances.
This is where silence ends and truth begins.
I have 150 pupils in one class.
Voice unheard.
Become a doctor in my future. That's why I'm studying right now.
Your story matters.
Welcome back to Voices Unheard. Of course, with me here in the studio is medical practitioner David Sanya and of course Emmanuel Kwaje, who's an activist. And today we are discussing about women's access to healthcare, especially sexually and reproductive health rights. You're both welcome back to the studio.
Thank you so much.
Before we went to the break, David Sanya, of course, we were talking about issues that you as medical practitioners face, and something that you had mentioned was about the issue of young girls, and actually this has actually become an issue. So what is the prevalence, do you think, of adolescents, pregnancies, and what are the specific challenges that some of these young mothers face during seeking of care in the health services?
The adolescent prevalence is very high. Of course, South Sudan is one of the countries that is highly rated when it comes to adolescence prevalence. The prevalence of adolescents currently is estimated at around 30% to 40%. Of young girls aged 19 to 14 to 19 giving birth. You find, and these are usually associated with issues to do with cultural beliefs. We understand the practice of early marriage in South Sudan is very common and it is highly practiced. But now, when we look at the impact of this child marriage on pregnancy, is the challenge. Because now, you can be married as a child, but you cannot be pregnant. But now, getting pregnant as a child puts these young girls into a very big challenge. Complications comes a lot. But when we look at the prevalence, it's very high and it is very common. So when we look at some of the issues that are causing this, the teenage or early child marriage, teenage pregnancy, of course we are looking at issues to do with the poverty. Poverty is one factor that has contributed a lot in teenage pregnancy. You find some of these girls, they cannot afford some of their basic needs. Sometimes even their family cannot afford their basic needs, so they send them out for marriage. Some of these young girls, they are not aware of their sexual reproductive health. They are not aware of their sexual health. They go and engage on sexual activities without knowing that I can get pregnant. But when they get pregnant, of course, the policy in the country dictates that there is no abortion. Abortion can only be approved if there is any medical conditions that is attached to it, being the risk to a mother, or to the child. So in that case, most of the families, they look at it like, why do we have to risk taking an illegal procedure when the child can even easily give birth? So what they said, of course, let's accommodate the pregnancy. A young girl will be pregnant, looking at the current situation, the young girl cannot be able to access nutrition services, because as a pregnant woman you need to have a very good diet so that you can have a healthy baby, and you as a mother you can also be healthy. But you find this young girl is not having health diet. Secondly, this young girl doesn't have access to medical services. She's in the village. You find there is stock out of drugs. You find there is no ferrous, there is no folic acid. You find, of course, we understand this is one challenge. You go to most of the health facilities, there are no drugs. They go maybe 1 month stock out. Some can even go 3 months stock out. So you find this young girl cannot access these health facility services. So they can be only doing the routine. You go to the health facility, they examine the baby is fine. But of course, there are basic needs that the child needs. So you find these young girls, they risk maternal death rises in the country. Yeah. This girl will be exposed to death during her birth, her delivery, sorry. Yeah. And the child also has a very high risk, or even premature deliveries. Sometimes you find even this child will be born with complications. Sometimes you'll have, these young girls also have very high chances of miscarriage. Yeah, which is the natural abortion. So there are a lot of complications that are attached to this, to teenage pregnancies. Yeah. But of course, the factors are very many. Of course, the forced child marriage is one of the factors, and it is one cultural practice that is very common. Economic barriers, of course, young girls usually feels like now influence also comes in. You find some girls, of course, I'm seeing one of my neighbors has an iPhone, and now I want to have an iPhone, not knowing that it is not the father of the, maybe it's the father that bought for the child. Yeah. But for you now, your parents are poor. What do you have to do? You have to engage yourself in sexual activities to gain those kind of material things. Yeah. Now you get pregnant, and then you risk your life. So economic factor has been also one of the contributing factors. We also look at some of the health awareness. Young girls, most of the young girls, they are not aware about themselves. You find they don't even know when I can get pregnant, when I cannot get pregnant. And in the community, we have this perception that when you talk to young girls about sexual education, it means you're teaching them how to do sex.
You're spoiling them.
You're spoiling them. Yeah. Not knowing that we are trying to let them know how they can make sure that they are very safe, because we understand the practice. You can find someone who is 17, 16, but the parents don't want to believe that their children are already engaging on sexual activities. Yeah. But the fact remains that even if we don't have evidence, we need to make sure that we give them education so that they become prepared of anything that will come.
They say prevention
is better than cure. Yeah. So we try to do prevention at least, but sometimes the community rises against that. But of course, the health policy says, of course, access to health information is a key. Every person has right to access to information, more especially on health. Yeah.
Okay, David, thank you for that. Because of time, I think we can move forward a bit. Let's go back to Emma Kwaje. Of course, when it comes to issues like GBV, a lot of women and girls report experiencing maybe physical or sexual violence. And of course, with stigma often inhibiting them from actually being able to access care. How can the issue of stigma actually be addressed in relation to access to health care in terms of this women?
So there are so many women that fear to be blamed, or they fear to be rejected. They also fear to be shamed by their families or the communities. When it comes to issues of GBV, you'll find sometimes they'll say, even it's because how you dress and all these things, that some other things happened to you and all.
So victim blaming.
Yes, so this is the problem. And then how we can be able to address this is we need to have a multi-level approach that all of us need to understand. That is by having community awareness. Because most of these things is from the community. You will find, you as a girl, something has happened to you, you'll find the whole community talks about it. I remember yesterday I was talking to somebody and he was telling me an example of how sometimes like in Nigerian movies, when, for example, your wife or did something, then elders will come and say, do you know this girl? This is the daughter of Filan, and who did this and this and this. So you see, you'll find the community talks about that, and it becomes very hard if you're somebody who you don't have any other person to speak to, you don't have any other person that you can be able to air that out. So it becomes very hard. Yeah. And another thing that can be done is like confidence and like the personnel. There should be a survivor-centered approach that should be there, so that the women can feel safe when they are going to report or when they are going to be helped. They go to the facilities. The health personnel should be able to give them an environment that is safe, that they can easily air out, they can easily talk. Sometimes so many people don't want to report or don't want to talk because they will be victimized. They will say other things to them that is not even helping them. And another thing is the personnel should also be trained. That is how we can be able to address. Just like he said, you find some other personnel, they even don't have very good communication skills. You go to them, tawali, you see? So it becomes very hard for me if I am going to report something or if I am going to access a service, or sometimes I will go and then I'll go and find it is a friend to my auntie, or it is a friend to my mother.
So there'll be that fear.
Yes, there will be that fear. You go there, they'll come and report. You will come and find you even went to just get condom. Maybe you're not even getting for yourself. You will come and find the whole village already knows that you went to what? To get this service from the hospital. So there is no confidentiality. So at least the personnel should be trained, and then they know, and then there should be a strengthening of legal services. Justice should be there, and accountability, because it becomes very hard. We find that there are some certain things happening, and then there is no accountability, there is no justice given. But there should these services, we have very good, by the way, we have very good laws and constitution, but it becomes very hard because implementation is a problem. So for us to have that, there should be the strengthening of these laws and strengthening of these legal systems as well. Yeah.
All right. We have just a few minutes left. I can ask, of course, the current landscape of the country is such that 2% of the country's national budget is allocated only to health. What role can the government play in offering better health services? Because as we're well aware, the health sector is held by mostly international organizations and stuff like that. So what role can the government play? Maybe medical practitioner, you can tell us just briefly, 1 minute. Yeah.
Okay, thank you. To me, I can say the budget has even dropped, the allocation has dropped. Yeah. When we look at the commitment of the government, in 2022, the government signed the family planning, the 2030 family planning implementation policy, commitment. So that commitment, it says the government is willing to increase the budget, and by then the budget was 2%. The budget was supposed to be increased to 8% by 2030. Yeah. And then, of course, the target is to make it at least 12% as the Abuja declaration. But when you look at the current situation, the government is even dropping from the 2%. In case of increasing, the government is even dropping. Last year, the budget was less than even 2%. It was 1 point something. But currently, even it is less than what was given last year. You see, even we are talking about 2% that is supposed to be increased, but the government is even dropping. But when you ask the policy makers, they will tell you, of course, the Ministry of Health has a lot of funding. There are a lot of partners supporting the Ministry of Health. Not knowing that these partners, they have a specific funded projects in the health. Yeah. Some not all the projects. Yes, some of them are responding to reproductive health. Some of them are responding to maybe only a specific component in the reproductive health. But now, what about the others? Looking at medical supply. Who is supplying the medical services? Yeah. Now you see UNFPA is supporting the government, supplying a lot of family planning commodities, from contraceptives, all the contraceptive methods. But now, looking at the distribution is a challenge again. The government the government cannot even come in to facilitate the distribution of these commodities. So the challenge is very, very vast. And when we look at the government right now, they are not caring about the health of the people, not knowing that a country without a good health is a country with a poor system. The health of the people has to come first, and then other things will follow. Because if the country is moving on with unhealthy citizens, where are we heading to? For sure. Of course, now we are almost coming to the end. If there's anything you'd like to add, we'll start with Emma Kwaje. If there's anything you'd like, this is the opportunity. Give us your final words, and then David, give us also your final words, and then we'll be able to close. Yeah.
Thank you. I think I'll also add to what you said. I think the government also has to have very good infrastructures when it comes to health services, as well as training and also retention of health workers. And there should be also supplies of these essential medicines, because sometimes, like some few months ago, there is a very essential medicine that is not there. Like literally the whole of South Sudan was not having. And you find children are born and it's not there. So it becomes very difficult. I think this is the government must really have very strong policies when it comes to that, and implementation and accountability as well. So I would also like to emphasize that women's access to healthcare is not just like a health issue, it is a human right as well. So women should, when women have access to quality sexual and reproductive health services, then their families will be healthier, as well as the communities will also be stronger because of that, and also the nations will develop faster. So it is very important for us to prioritize this dignity and also prioritize equity and also access for all women to be able to access these services. So we all have a role to play, creating awareness, engage with the families, the elders. They should also know their roles when it comes to that, and also the government should know their role by providing these services. Even the health workers should also learn to have confidentiality and also have very good communication when it comes to women or girls coming to access services.
All right, thank you. David, final take and then we will close.
I think, thank you so much. The final take I can give out to people listening out there is that health is not just about you visiting the health facility, but it's about also understanding how you can keep yourself safe. You can be healthy without knowing, but you can also be unhealthy without knowing. So it's very good for every mother out there to ensure that they visit the health facility, to ensure that the safety of their child and their safety is also taken care of. The service is 100% available and it is free of charge. Of course, challenges may come in, but at least challenges are not more than what can be achieved. So let us always ensure that we visit the health facilities, and then we are also able to check ourselves, more especially to the young people. Avoid engaging in sexual activities without protection. HIV is real, and it is the prevalence is of course rising every time. Let us ensure that we are out there to prevent ourselves from unwanted pregnancy, sexual transmitted infections, and also ensure that we are very safe and healthy. Thank you so much, and I hope to end here.
Yes, thank you very much, Makoje. And thank you very much, David Sani, actually, for coming and giving our viewers this very important feedback, actually, or important take on issues to do with access to women's health in the country. Thank you very much for coming. Yes. Okay. According to Article 25 of the Universal Declaration of Human Rights, everyone has the right to a standard of living adequate for the health and well-being of himself and his family, including food, clothing, housing, and medical care, and necessary social services. Dear viewer, we have come to the end of our program that has been Voices Unheard, where we focus on human rights and uplifting marginal voices. I have been your host, Emmanuel Amin. Join our team in the next episode, and until we meet again, have a lovely evening.